Hello, everyone. We are very excited to welcome you to this session, focusing on experience of care and mistreatment of women during childbirth, where we will hear the latest evidence around measurements and discuss emerging issues and lessons and directions to inform policy and programming. I am Dr. Özge Tunçalp from the World Health Organization, and with my colleague, Dr. Patience Afulani from University of California, San Francisco, we will be moderating the panel today.
Hello, everyone. It is a pleasure to be here. Following the increase in facility-based childbirth in many low and middle-income countries, the emphasis has shifted to improve quality of care within healthcare facilities, which includes women's experiences of care. Respectful care is a key aspect of good quality care, and mistreatment can be a deterrent to women who seek facility-based care. This has implications for clinical outcomes and human rights across low and middle-income countries and also in high-income countries.
And this issue is especially critical given the pandemic we are going through. And without further ado, we would like to give the floor to our esteemed panel of speakers from Nigeria, Canada, Ghana, Australia, and the United States.
After the presentation, we will have approximately 10 minutes for moderated Q&A. We'll also do our best during the presentations to answer questions in the chat. To save time, each panelist will introduce themselves at the beginning of their presentation.
So I'm going to be presenting how women are treated during childbirth, evidence from WHO multi-country study. I'm Dr. Teresa Iriyenikon. I'm from the University of Medical Sciences, Ondo, in Ondo State, Nigeria. And I'll be making this presentation on behalf of the WHO Mistreatment of Women Study Team. In 2010, Bowser and Hill did a landscape analysis to outline the issue of disrespect and abuse during childbirth. And in 2011, the White Ribbon Alliance Respectful Maternity Care Charter instituted universal rights for childbearing women to address the issues of disrespect and abuse among women seeking maternity care. In 2013, WHO had a technical consultation to develop a universal typology of the mistreatment of women during childbirth and to initiate research activities to develop, to validate, and to apply measurement tools to measure the prevalence of these mistreatments. And so in 2014, WHO came up with a statement, Prevention and Elimination of Disrespect and Abuse During Childbirth, which has also been published. Now, several phenomena have been used to coin the word mistreatment. For example, obstetric violence is commonly used in Latin America. The word disrespect and abuse is also commonly used, and also respectful maternity care. And these ones have been published in several journals. The typology of mistreatment, how did we come about it? WHO conducted a mixed method systematic review to develop a typology of what actually constitutes mistreatment of women during childbirth. And they conducted this study used from 65 studies across 34 countries. They came up with typologies like physical abuse, verbal abuse, stigma and discrimination, failure to meet professional standards of care, poor rapport between women and providers, and health system conditions and constraints. And this has also been published in the PLOS journal. Now, the WHO multi-country study, how women are treated during facility-based childbirth. The overall aims and the objectives, they were to, one, to develop and to validate tools that can measure this phenomenon. And secondly, to explore individual, provider, institutional, and health system factors that are associated with mistreatment during childbirth in health facilities. Now, we conducted this study in two phases. The first phase was a qualitative formative research to explore what constitutes mistreatment during childbirth, and this has been published in several journals. The second phase was to develop and to validate two tools to measure mistreatment during childbirth. And those tools were one, labor observation tool, and also the community survey tool. And we conducted the research in 4 countries, in Nigeria, in Ghana, in Guinea, and in Myanmar. Now for the phase 2, we prospectively recruited women that were aged at least 15 years in 12 health facilities in Ghana, in Guinea, in Myanmar, and also in Nigeria. Data collection started between 19th of September 2016 and 18th of January 2018. For the labor observation tool, we continuously observed women who were admitted for childbirth from the period of admission up to 2 hours post-delivery. And for the community survey tool, surveys were administered by interviewers who were not clinicians in the community to women who delivered up to 8 weeks after delivery. So data were collected on social demographic, the obstetric history, and also experiences of mistreatment based on the typologies. And this has been published in the Lancet Journal of October 2019. Now, overall overview of the sample. For the labor observation tool, we screened 2,806 women. But for one reason or the other, for eligibility purpose and also not giving consent, we were left with 2,016 women which were analyzed. Out of these 2,016 women, 45.9% were from Ghana, 33.8% were from Guinea, 20.2% were from Ghana, from Nigeria. However, Myanmar, it was not, labor observation was not observed in Myanmar because of ethical reasons. For the community survey tool, we screened 3,806 women. For one reason or the other, lack of eligibility and also loss of to follow up, we were left with 2,672 women for analysis. And out of this, 31.3% were from Ghana, 24.1% were from Guinea, 23.6% were from Myanmar, and 21% were from Nigeria. Now, we noticed that many women experienced mistreatment during childbirth. Among the 2,016 women that were observed, 41.6% of the women were observed to have had any physical, verbal, or stigma and discrimination. And this was reported as well in 35.4% of the women. Similarly, any physical abuse, any verbal abuse, any stigma and discrimination were both observed and also reported among the women. Now, when we look at any physical abuse or verbal abuse, we notice that the incidence increased 30 minutes before delivery up to 15 minutes after delivery. And it actually peaked 15 minutes prior to delivery. And so we noticed that the women, they were 11.6 times at increased risk of physical abuse compared to 1 hour prior to delivery. And they were also 6.7 times at increased risk of verbal abuse compared to 1 hour prior to delivery. Many women experienced unconsented procedures, but about 10.8% of the women did not give consent for cesarean section. 56.1% did not give consent for episiotomy. 26.9% did not even give consent for induction of labor. And many of the women also experienced unconsented vaginal examinations. 59% of the women observed did not even give consent for their first vaginal examination. And this occurred in 4.6 times among women who were younger and who were not married. Women who reported no use of privacy measures, such as curtains, they were 3.4 times more likely to report lack of privacy compared with women who had privacy measures used. Now, many women experience mistreatment during childbirth. Younger women, they were 1.8 times more likely to experience physical abuse. And those with no education were 3.6 times more likely to experience verbal abuse. Now, what are the implications of our findings? We noticed that we need to redesign our labor wards to allow for privacy and labor companionship. We need to improve on effective communication and informed consent process for all medical procedures. We need to provide sufficient mentoring and support for health workers to empower them to provide better quality care. And we need to build on public demand for high quality maternity services that will provide women-centered care and that will not tolerate any form of mistreatment. Now, based on our published evidence in October 2019, stakeholders in Guinea developed recommendations to reduce mistreatment of women during childbirth. So in May 2020, it was adopted by the Ministry of Health of Guinea that this has to be included in Guinea's reproductive, maternal, newborn, infant, adolescent, and nutritional health strategic plan and the Muskoka Action Plan of 2021. And so I quote what one of the head wife of a maternity ward in Guinea said. She said, "We shared recommendations widely with actions to improve respectful maternity care in our hospital." This was stated by Mrs. Hawa Keita. I want to say a very big thank you to the countries where we conducted this research, to Nigeria, to Ghana, to Guinea, and to Myanmar. We want to say a very big thank you to the research assistants who were involved in the data collection. We want to say a very big thank you to the women that participated even in the research. And we want to say a very big thank you to the principal investigators that coordinated the research in the 4 countries, and also to the principal investigators and the members of the USAID that were present in Geneva at the principal investigators meeting in July 2018 to deliberate on the findings and also the dissemination of our findings. Thank you very much.
Good morning. My name is Vedam. I'm coming to you from the traditional and unceded homelands of the Musqueam, Tsleil-Waututh, and Squamish nations in Western Canada. Measurement to establish prevalence and types of mistreatment in low and middle income countries has been increasingly robust, as you will hear today. I'm going to share our findings from high resource countries across the same domains of respectful maternity care. I think everyone would agree that to have credible, usable data, we need to ask the right questions in the right way, ask the right people, and ask enough people. Today, I'm going to talk to you about how to ask the questions the right way. I run a lab called the Birthplace Lab, and we are committed to community-based participatory action research. And that means including service users in the design of instruments to measure their experiences of care. I'm going to describe the process and share some of the results of applying our person-centered measures from 2 of our previous studies in Canada and the US, where more than 6,000 people shared their stories. These are the studies that I'm going to focus on today: Change in Childbirth in BC and Giving Voice to Mothers. In all of our studies, we use a process where we start by creating a multi-stakeholder team, and the service users and a multi-stakeholder team decide together what to ask. We seek the funding together. We describe and identify what to study, how to study it, what those measures should be. We work together to recruit the participants, and the service users also lead the way when we're exploring the findings, identifying the key messages, and deciding how to tell the story. The process of co-creation for measures and metrics means that you have to first address power and build trust. So we start by convening a steering council of service users who have the lived experience of whatever community that we are trying to understand their experiences for. And we, of course, do pregnancy and childbirth care, so that health services for people, various people with various identities who are experiencing pregnancy and childbirth. Our stakeholder teams often have clinicians, NGO leaders, community advocates, and community health workers. We start by doing a literature review, looking at validated items that exist to measure the domains that these service users want to. So if they say, we want to measure respect or decision-making or preferences for care or choice of birthplace, we look for what's already been published. When those items are not available, then we will adapt or design new questions, and the community members will be rating each item for relevance, clarity, and importance. And there are ongoing, repeated community consultations throughout the whole process. In our current study, which is a national study, the Steering Council recommended using a variety of images also when we did the recruitment to ensure participation from people with various identities, circumstances, and backgrounds. Here's a taste of the type of validated questions and scales we've used and the results that we've gotten. The first is the Mother's Autonomy and Decision-Making Scale. It's a reliable and valid tool that rates the level of agency and autonomy that a person experiences when participating in decision-making conversations with their provider. The MADAM scale is completed by pregnant people, and I'm going to now show you some results from a large sample in the US. We had respondents from all 50 states, and as you can see, the respondents mirrored the population density that exists in the United States. We deliberately oversampled for communities of color. That was the goal of the study. In this study, we found that there was lower autonomy depending on your place of birth. And in fact, facility birth always produced lower autonomy than being in the community. There was lower autonomy when people were cared for by physicians versus hospital-based midwives, and higher autonomy when community-based midwives were involved in their care, even if they transferred to a facility. We also have a measure of respect. This measure, 14-item measure, is a scale that measures across 3 constructs: how comfortable they felt asking questions, accepting or declining options, whether the respondents felt discriminated against because of their identity or difference of opinion, and how that affected their behavior. Did that make them hold back their questions? Interestingly, we found that if there was a difference of opinion, there was very low experiences of respect. When we looked at this we looked at it across many predictors, and we certainly found that place of birth mattered, type of provider mattered, mode of delivery mattered, but there were particularly significant differences by race. People of color reported the lowest levels of respect in our whole study. Community members told us that these types of mistreatment are milder than what they do have experienced, that they would name mistreatment. So we created this mistreatment index of 7 items where they were able to report on whether their personal information was shared, if they were shouted at, scolded, if treatment was withheld or forced, or if healthcare providers ignored them, refused to help them, or failed to respond. 1 in 6 women, 17% in our full sample, experienced 1 or more types of mistreatment. Being shouted at or scolded by a healthcare provider was the most commonly reported mistreatment, followed by healthcare providers ignoring them, refusing their request for help, or failing to respond. Rates were 2 in 6 among Black and Indigenous and people of color, and even more they were even higher, these higher rates of mistreatment when people had social disadvantage. Marginalized communities globally experience the same level of mistreatment. You can see here it's 1 in 3 in LMICs and 1 in 3 in Black, Indigenous, and people of color. And it's when they decline care, it gets even worse. Women of color were 2 times more likely to have the procedure performed against their will, or be pressured, where providers kept asking them until they'd agreed, and no one stood up for them. We asked all of that, and even what happened when they declined, we measured. Half of the way they gave birth affected their rates of mistreatment. Place of birth affected their mistreatment. Community birth settings were protective of mistreatment. And of course, social disadvantage was absolutely linked to mistreatment. In our current study, we're currently engaged in a national study of respectful maternity care across Canada. Nearly 6,000 people have participated to date. The survey instrument was designed over 2 years using an intentional participatory process. We started in this process by doing a global scan for validated items to see what were the best ways to measure respect and disrespect in a high-resource country. We had a transdisciplinary panel, including service users, clinicians, health systems leaders. We did a Delphi process. We came up with 210 final items, mounted them on an open source registry, and you can see here that we have the 7 domains of mistreatment that Boren and colleagues have described, as well as 5 additional new domains, which the service users told us that we needed to measure the opposite. What's exceptional kind supportive care in order to be able to inform system change. So we gathered those items, designed some new ones, and adapted them to the first person. You can click on any one of those domains. It will take you to the items themselves, the measures, these validated measures. They are sorted by domain. The healthcare worker or staff threatened that if you didn't comply, you and your baby would have a poor outcome. If you click on that item, then it will take you to the source for the original item, and the item is, we adapted it for the respect study. In our preliminary analysis of our national respect study in Canada, where we have over 6,000 people already who've participated, we also included its discrimination index. And sadly, we are finding, again, that it's possible to measure disparities in mistreatment among marginalized populations. And in Canada, Indigenous, people of color, sexual and gender minority identity, people with those identities have significantly more likely to experience discrimination and mistreatment. So finally, I just want to say that if we want to co-create an anti-oppression health system, we have to work with communities so that the right information reaches the right people in the right way, and we ask the questions in the right way from their lived experience. What does mistreatment look like? Thank you.
Well, I bring greetings from Ghana. I am Kwame Edu Bonsafo, presenting on behalf of WHO Mistreatment of Women Study Team. I'm talking on exploring mistreatment of women and quality of care using WHO multi-country survey. As my colleague Teresa has already explained, after the publication of the main results, we started working on prioritized research questions using the study database. These are some of the prioritized analysis that we've been working on: labor companionship and mistreatment of women, satisfaction of care, adolescents' experiences, measures based on labor observations, and the rest. In this presentation, I'll focus on the first two: labor companionship and satisfaction with care. All these will be included in the forthcoming Global Health Supplement in summer this year. So we can see that a lot of work has been ongoing in recent times on companion of choice during labor and childbirth. A lot of evidence, both qualitative and quantitative, have been synthesized, showing positive maternal and newborn outcomes. And these have resulted in evidence to action brief by WHO. And this has also been included in 4 WHO guidelines, including the one on intrapartum care. For this analysis, the objective was to explore the relationship between labor companionship and mistreatment of women types. And of the 2,672 women across Ghana, Guinea, Myanmar, and Nigeria, about half reported the presence of labor companion. Women in the absence of labor companions experienced some form of mistreatment, but this association varied depending on the country. For instance, in Guinea, it was 3.6 times more likely among women that experienced any physical abuse, verbal abuse, stigma, or discrimination. In Ghana, it was 2 times more likely among women who experienced non-consented vaginal examinations and 2 times more likely among those who experience poor communication. There are a couple of implications that our study highlights: that the labor companions can be important in improving respective maternity care, and the association between companion and types of mistreatment vary by context. Facilities can establish supportive policies that allow and encourage women to have companions during labor and childbirth. And support of companion of choice during labor and childbirth is a practical intervention that can be implemented to improve both provision and experience of care. So another area of research relates to the importance of accurately measuring experience of care and its relationship with satisfaction. A number of reviews have been conducted, and they found the following: that existing facility assessment tools provide a valuable way to assess quality of care, but many do not include experience of care measures. Many instruments that exist need to be consolidated, validated, and expanded. There are a limited number of studies assessing how programs or policies affect user experience. And there is a need for more nuanced interpretation of satisfaction measures in relation to experience of care. For this analysis, we explored the association between women's satisfaction and mistreatment of women. Despite the fact that 1/3 of women reported experience of mistreatment, majority of them were satisfied with the services they received and would recommend the facility to other women. Women who reported experience of care were more likely to report lower satisfaction, and this is a different picture from the initial finding. For instance, women were 4.5 times more likely to be satisfied if they did not experience verbal abuse, and were 5 times more likely to be satisfied if they had short waiting times. So the implication of this research work includes the fact that measuring both women's experiences and their satisfaction with care are important in improving the continuum of maternity care services. Also, measuring experience of care provides important information about women's interaction with the health system and health providers that may be missed if only satisfaction is measured. These measures are considered process measures that can enable health systems to identify and respond to root causes contributing to measures of satisfaction. So, what are the mechanisms that are in place to ensure that these evidence is actually informed practices at the facility level to enable respective care? One of those mechanisms includes implementation of WHO guidelines, antenatal, intrapartum, and postnatal guidelines. Another important mechanism is the quality of care network, which aims not only at having the maternal and newborn deaths, but also improving the experience of care. Before I close, I would like to highlight the importance of caring for carers. As we know, women, midwives are central to maternal health care, and they provide significant proportion of maternal care to women. It's surprising that recent evidence indicate that midwives experience significant level of disrespect, violence, harassment, and unsafe and fear. And they are also treated badly. They experience significant social, cultural, and economic and professional barriers, leading to more moral stress and burnout. And this significantly affects their output. In moving forward and wanting to improve or provide optimal care for women, there's a need to address considerably the plight of midwives who also provide significant care for our women. So at this point, I would like to acknowledge the importance or the important contribution of our principal investigators, our WHO partners, our research assistants, and the women who were included in the study. Thank you very much.
Hello. I would like to begin by acknowledging the traditional custodians on the land on which I am today, the Wurundjeri people of the Kulin Nation. I pay my respects to their elders past and present and extend that respect to all First Nations people here with us today. My name is Megan Boren, and I'm presenting on behalf of the WHO Working Group on Interventions to Reduce Mistreatment of Women During Childbirth on moving from evidence to action to promote respectful care and reduce mistreatment during childbirth. In the previous sessions, we've heard about the importance of inclusive and participatory research and how to develop and validate measures to better understand women's experiences of pregnancy and childbirth care. Because of these efforts, we now have a good understanding of how to measure these experiences, which were previously left behind. So where do we sit today with moving forward to ensure that all women have a positive childbirth experience? The 2018 WHO recommendations on intrapartum care for a positive childbirth experience specifically recommends respectful maternity care, as well as several other interventions or care models related to respectful care. This includes things like effective communication between the care team, the woman and her family or supporters, companionship during labor and birth to support her, promotion of oral fluid and food intake during labor, as well as mobility and upright position, continuity of care and carer, maternal mobility and upright position, pain management, including both pharmacological and non-pharmacological options. However, these interventions alone are insufficient to ensure that all women have the right to respectful maternity care, and there's an urgent need for evidence around how to effectively design interventions and services to reduce the mistreatment and promote respectful care. The mistreatment of women during childbirth is about denying women autonomy and agency, although different types of mistreatment, or even in some cases the same types of mistreatment, can have different and multiple causes. For example, denial of pain relief may be due to stockouts, such as system constraints, which may or may not be due to deprioritizing women's health needs, or may also be due to intentional or unintentional denial due to gendered stereotypes around women bearing pain. This effort to prevent women from exerting full control over their bodily autonomy and decision-making is reflected in both laws and policies. Harmful gendered stereotypes, for instance, around women's decision-making competence, women's roles in society and motherhood, fuel these laws and practices that deny women's reproductive autonomy during childbirth. Similarly, all forms of mistreatment against women constitute gender-based discrimination, which is often further compounded by other forms of intersectional discrimination faced by these women in the context of childbirth. For instance, women from minority racial or ethnic groups, women of lower socioeconomic status, women from migrant and refugee backgrounds, women with disabilities, and people giving birth who don't identify as women may be more likely to experience intersectional discrimination across multiple fronts. Power dynamics and understanding power can help to understand how mistreatment occurs and how we can best address it. Lastly, health system conditions and constraints play a role in driving mistreatment, and they can be also directly experienced by women as mistreatment. To truly promote respectful care for all, we need to understand and then disrupt these harmful norms. Our first step in this process is conducting a series of 5 systematic reviews to understand drivers of mistreatment and to map the pathways in which they occur in order to identify potential interventions or components of interventions to promote respectful care. These reviews are led by the WHO working group members and their teams across the world. The first review focuses on power dynamics and uses critical interpretive synthesis approaches to review literature from different disciplines and subject matter areas in order to critically synthesize evidence on drivers of mistreatment. The review team here aims to generate novel evidence-based theory that can inform future research questions and testable hypotheses regarding the upstream drivers of mistreatment. The second review aims to explore key organizational factors that impinge on provider behavior and patient experiences, with a focus on public healthcare institutions in low and middle income countries. The team is exploring how the organization of care may be influenced by or is a response to resource constraints, and aims to identify the changes to how care is organized that may improve provider behavior and as well as patient experiences. The third review aims to explore which strategies have been implemented to improve effective communication, both between health providers and the women and their partners or families, along the continuum of maternal and newborn care. The review team plans to understand how effective communication is conceptualized and measured across different studies and in different contexts, as well as what factors might influence the implementation and effectiveness of communication strategies. The fourth review aims to establish theoretical principles and mechanisms of what works to reduce physical and verbal mistreatment across the spectrum of health and social care. Drawing from these other health and social care settings, the review team will then generate ideas as a basis for designing effective interventions for maternity services in the future. Lastly, the fifth review aims to describe interventions to reduce stigma and discrimination in sexual and reproductive health services globally. The review team aims to assess the effectiveness and analyze characteristics of effective and ineffective interventions, as well as to synthesize the key stakeholder experiences of interventions and their perceptions of the feasibility, acceptability, and effectiveness of these interventions. Our portfolio of work on interventions to reduce mistreatment and promote respectful care parallels the core drivers of the Align MNH initiative. When we align our priorities to amplify the voices of women and communities, we believe that we can then act for a better future for all. To do this meaningfully, we must account for complex social norms around gender, racial, and power dynamics, as well as address inequalities to ensure that all people can actualize their rights to respectful care. Women and communities know what's important to them. We must engage with participatory partnerships in order to find out. Our evidence from this series of reviews will be used in knowledge translation tools and guidance to inform country-level programs and policies. Thank you for joining us on behalf of the WHO Working Group on Interventions to Reduce Mistreatment of Women During Childbirth.
Hi, everyone. Can someone confirm that you can see or hear?
Yes, we can see it.
Perfect. Thank you, Patience. Wonderful. Hi, everyone. My name's Emma Sachs, and I'm
Emma, we're not seeing your slides. That's better. Now we're seeing the proper slides. Yeah, thanks.
okay. Fantastic. Thanks. And I'm also presenting on behalf of the WHO multi-country study team. So you've already heard quite a bit about the really wonderful work that's being done around respectful maternity care. You may have seen this framework on the left here showing quality of care and the inclusion of both provision of care and experience of care. And I just wanted to highlight also that along with the standards and the framework developed for maternal and newborn care, there's also one around pediatric care and one specifically for small and sick newborns. So I'll be speaking today about a secondary analysis that we were able to do with this same data set to look at newborn care practices during those first 2 hours after birth. So the methods that we use for this analysis were to only focus on the labor observation tool, which was available in 3 of the countries out of this larger study. As you heard, there was continuous one-on-one observation. In order to look at practices that should have been received by every newborn, so really focusing on routine care, we narrowed our analytic sample to what we would consider low-risk infants. So we only included singleton and firstborn twins and vaginally born infants. And then we selected indicators that were recommended for every newborn. And another sort of unique thing about this data set is that it allowed us to link the maternal and newborn data, since demographic and observational data were collected on both. So I'm going to present sort of some of our very top line findings. It was published in Lancet Global Health late last year, and the title and citation is at the top. So we were able to collect data on over 1,600 maternal newborn dyads, and we found a very wide range when it came to prevalence of recommended and non-recommended or potentially harmful practices for newborns. For example, we saw very high prevalence of newborns receiving delayed cord clamping. More variable were things like skin-to-skin contact. And then for those practices that were not recommended, we saw more than half of newborns were separated from their mothers in the first 2 hours. Because of the nature of this study, we were not able to sort of get all of the nuance about exactly why the separation happened and for how long. But given the high prevalence, it's likely that most of this or much of this was not for medical necessity. And because we collected demographic data, we were also able to stratify, and we were able to see that separation was more common for mothers who were single, even after adjusting for other factors. We also had breastfeeding indicators, and we found that only 24% were breastfed within 30 minutes. And again, we were able to see an association between lack of maternal education and low birth weight newborns also not receiving those or less likely to receive recommended newborn care practices. And finally, as I mentioned, because we were able to link the data between sort of maternal experience and these selected newborn care practices, we found that when women had experienced physical abuse from providers, the 1 hour before childbirth, their newborns were more likely to be slapped. And I think a lot more research is needed to try to understand, as you've heard a bit about from earlier presenters, around the drivers of this and whether this is because it's the same provider or because there's some shared characteristics between the mother and newborn for which they are experiencing some kind of stigma or discrimination. I won't go into detail about this, but just to say that we did look at the differences between the countries and a couple of other indicators, including some such as refusal to provide care due to lack of payment, which were rare but quite serious. And so this is available in the paper if you're interested in those details. So just to talk about some of the implications, overall, I think this really shows that many newborns are not receiving the full complement of evidence-based care. And some of these practices may be considered mistreatment. For example, newborns being slapped, although it's possible that this is because of outdated training of providers who are actually well-intentioned and trying to provide the best care possible. And as I mentioned, I think there's a lot more research that needs to be done about the drivers of this. Many of the practices that are not being done universally are relatively low cost, right? So things like skin to skin and breastfeeding promotion that really should be encouraged everywhere. That's not to say that they don't have a cost, but sort of compared to a number of other interventions should really be prioritized due to their high impact and low cost. And I think also, you know, as has been brought up before, these experiences could be driven by infrastructural issues, structural issues, interpersonal issues, et cetera. So it's important that policies are set that support sort of health promoting practices and recommended newborn care practices, including no separation of newborns from their families. So as I mentioned, a need to provide, to continue doing research in this area. So there's ongoing work in trying to understand local and cultural understanding, scoping some of the tools we'll be able to use, and understanding drivers. I think very far in the future, we'll need, or maybe not so far, to start testing and evaluating some of the effective interventions. I've included a couple resources here on some other recent work, including a large study similarly looking at practices in Nepal, and a preprint of a study in Kenya looking at the impact of separation on subsequent care utilization, satisfaction, and breastfeeding practices. Finally, I just wanted to mention, as many of you probably know, the WHO guidelines on postnatal care are being updated, and there's a real emphasis on a positive postnatal experience. And so a number of studies are feeding into this that include looking at what matters to women in the postnatal period and what are the factors that influence the uptake of routine postnatal care. Thank you very much.
Thank you very much, colleagues, for the very insightful presentations. Now I would like to ask you some questions. I'd like to start with Dr. Iri Yaneka and Dr. Bonsafo. So you conducted and shared the results of the WHO multi-country study. Could you please share the experiences or any future plans of applying the evidence to inform policy and or practice in your respective countries?
Well, I'm speaking, Dr. Teresa Iriyeniko from Nigeria. I want to share our experiences following the publication of the study in 2019 October. When we published that study, we had an advocacy visit to the policymakers. And here in Nigeria, we have, especially in the states, we have commissioners for health, we have permanent secretaries who are heads of health, Ministry of Health, and they control the health facilities in the states. So we paid advocacy visits to them and we told them about our findings. So immediately they ordered that the labor wards should be redesigned such a way that to ensure privacy and also to encourage labor companionship. And so today, our labor wards have been partitioned. So every woman is partitioned. She's in her own cubicle with a labor companion of her own choice. That is one experience. Then they also looked into our consent forms. And so they have improved upon our consent forms to accommodate obtaining consent for all procedures during labor. And so if you want to do any procedure on a woman, you must take consent. Is that you take a verbal consent or you take a written consent? Without a consent, you cannot just jump on any woman that you want to do a vaginal examination. So this has resulted from the study that we did in 2019, from this study. So also, we have looked at how we can get feedbacks from the women. And so we created points that we called Cervicon points, where women can give us their feedbacks of their experiences during labor. And so these ones have been strategically located within the hospital, such a way that every woman that has gone through labor can drop whatever feedback that she wants to drop in the box, and she will not, without even stating her name. And so the fear of this has made the midwives to actually wake up, that people can even report them to the authorities. And so that has improved and reduced the incidence of mistreatment among the women. So also we have engaged non-governmental organizations that can fight for women's rights. And those women, the NGOs, they were actually involved to create awareness among the women about respectful maternity care. And also for women, that when they are also mistreated, they can also approach them to fight for their rights. And that one too has also gone a long way to reduce the incidence of mistreatment among our women. Then we look at some other reasons why the health workers actually mistreat the women. Some of them, they claim that their welfare was not really taken care of. They tend to divert their anger on the patients, on the unknown patients. And so in that case, we have looked at their welfare package. And so government has actually improved the welfare package of the health workers so that they have a kind of a job satisfaction. And so with this, they're able to reduce their anger on the patients. And so they have reduced the incidence of mistreatment has been reduced. What I'm saying is within the states, Ondo states, but we still need to take it further to a national level so that this can actually cut across all the states. This is for Nigeria.
Thank you, Teresa.
Well, thank you for the question. In Ghana, since the publication and the work that we did on mistreatment, a lot of discussions have gone on, including many stakeholders, the health professionals, and then also the health administrators. And this is known also countrywide. But we have also initiated measures to try to reduce mistreatment of women. As you know, the study has shown that it's very prevalent in the country. And we also know that mistreatment actually is a disincentive for women to seek care in future. And therefore, we have made certain provisions to try and improve mistreatment of improve respective care. For instance, I can say we haven't actually put in all the interventions yet, but curtains have been provided in the hospital where I work. That is the biggest hospital. So now, when you come to labor ward, you see that women are partitioned, even though they are all in the same labor ward. For some other labor wards, we have them in their individual rooms. And for the general ones, it's surprising that for the individual rooms, now we are able to accept pet companions of choice by the woman to come and be by them because they are in their own labor wards rooms. But for those in the bigger room where they have curtains, it's still not possible. But I can assure you, these things are things that we are really considering actively. And then we are planning, because some of these labor wards are already built and plans are far advanced in trying to improve upon that so that women can get a companion of their choice in the time of birth. And also, I can say that a lot of other studies are also being carried on based on what we have found. In Kumasi, for instance, I read about a study on midwives. This is because the carers, we have to take care of the carers themselves, caring for the carers, because it turned out that they also have specific issues, maybe social, cultural, and other things. And studies show that those are the things that actually will cause them to also mistreat people, because then you don't understand why a human being will mistreat another human being. So based on that, the hospital, this is a teaching hospital, we have instituted a policy where we try to motivate best workers, we encourage them. And when we do things like that, these have actually started improving the care that we give women. But as I'm saying, these are all done at the institutional level. There's a need for us to actually make it at the higher or the national level. I mean, the Ghana Health Service is actually interested in providing respective care, but there are other socio-cultural and other challenges that actually not helping to get it fully implemented. But I can assure you that these things, we are aware of it and steps have started. And so the new facilities that are going to be built, we are going to factor some of these things into that. Coming to how women can, be treated well, there are also opportunities for women to actually report their experiences after childbirth and being discharged. And these are measures that we have taken or put in place to make sure that we improve the care that women receive and improve effective maternity care. So these are some of the things that we in Ghana are doing. We are aware of the problem, the enormity of the problem. We have started methods or interventions to try to reduce it in the country. And for now, we have started from the institutional level. Thank you very much for the question. Yeah.
Thank you very much for these insightful comments and experiences from the countries. I would like to ask the next question to Emma, who presented on the issue around newborn health as the missing link. So just very briefly, what are the lessons learned from the work on maternal health you think can inform and accelerate respectful newborn care agenda to ensure that we have the mother and baby together moving forward?
Yeah, absolutely. Thanks. Obviously, I think there's a lot of lessons, and we're lucky to be able to sort of expand on an existing agenda where there's been so much work already. Very briefly, and I think it's been touched on, sort of thinking a lot about the role and the needs of the healthcare providers is, I think, something that is a clear lesson from the work on respectful maternity care in general, which is that we really need to understand the constraints that the healthcare workers themselves are working under. And when we think about their, being one provider for mother and newborn and other family members and other things going on, it becomes easier to understand sort of those stressful situations and limited time for training and updating their skills and things like that. So I think that's one piece of it. And I think a related issue is actually around language, right? And that if we think of the providers as also really wanting to provide high quality care and being in a team with women and with all of us researchers and advocates and programmers, that sometimes the language can make people defensive, that if people are really trying to provide the best care, then sometimes calling something abusive when it's really a provider doing the best that they can sort of creates a chasm between the different stakeholders. So I think as much as we're able to try to listen both to families and to providers to think about the ways that these strategies can address everyone's needs and really advocate for system improvement as a whole. And so really using a systems lens and making sure our language reflects that. Thanks.
Thank you, Emma. So our last two questions are for Dr. Verdam and Dr. Boring. So how can we use the current evidence on measurements and drivers of mistreatment to inform strategies moving forward? What will you say is the next frontier?
I think rather than hearing from me, we should listen to the people who are most affected. And we have done town halls across North America after doing these studies to ask the service users, what would you like to see? And universally, they say they want to see their human rights to be held up as a standard of care. They want us to measure undisturbed birth rates alongside cesarean rates. They want us to measure respect and disrespect alongside models of care and the impact of place of birth, type of provider. They want us to measure things like racism and anti-racism, both sides of the coin. What produces positive care also. Many of them talked about social media campaigns to raise awareness among the service users themselves. They talked about hashtag birth assault, hashtag undisturbed birth, hashtag my body, my birth. They talked about having celebrities and spokespersons to elevate attention to this, training for leaders and health professionals, religious leaders, access to midwives and doulas. They wanted accountability. They wanted those measures to be at the service provision. They wanted to be able to report about their own experiences at the time of service or shortly thereafter. And they wanted to see that those data be looped back into quality improvement. So as I said, undisturbed birth is a standard of care, funding to support and incentivize re-education, accountability, transparency, and education of health professionals around trauma-informed care, around anti-oppression, around what mistreatment looks like. So they have a lot of ideas, and I think we have some responsibility to respond by creating, we've created a tracking mistreatment online tool. We've created a course, a 5-module online course to teach health professionals about what person-centered decision-making looks like. And then the Birth Rights Bar has created a lot of very simple, what you can do during a violation. Delay and buy time, document what's happening, restate your needs, helping service users to find their voices and to call out. But they can only do that, of course, if it's safe, if the system itself supports their rights. So those are my thoughts. Thank you. Megan.
Great, thanks, Saraswati. I think you've done a really great job of highlighting the complexity of these issues, and I would echo everything that you said. And just to sort of extend on what all of the panelists have said so far today, I think we've got a pretty good understanding now of how we can use different measures around mistreatment and respectful care, as well as a really a much deeper understanding of the systemic drivers related to women's poor experiences of maternity care. We know pretty well about how the structural dimensions influence women's experiences like gender, power, and social inequalities, about racism, about judgments about women's sexuality, and about their bodies. I think moving forward, we really need more work to ensure that any sort of interventions or quality improvement initiatives really account for societal context. And we need to really think about how we can reorganize these institutional structures and processes in order to provide better care that are centered really on the needs of women and communities directly. I think it's really important to highlight, again, the complexity of this work, that something like a once-off training on respectful care probably isn't going to be sufficient to achieve these lofty goals that we have. And what we really need to have are these community-driven, high-quality implementation research types of projects that address these systemic challenges. So something like this might be optimizing the birth environment to make sure that it's more centered on the woman's needs and the family's needs to support her. To train providers to better care for women in different birth positions of her choice, something that's comfortable and empowering for her. We might also need to think about what sort of systemic changes that we need to have in order to allow women to have someone there to support her throughout labor and birth. But I think it's also, just to come back to a point that Kwame made earlier, it's really important that we can include how we can better support healthcare providers, and especially midwives who are often suffering from burnout and chronic stress from really, really tough working environments. I think it's really important in the context of the Align MNH initiative as well to make sure that we're agitating for change to shift the balance of power from systems back to the people and ultimately to women and their families themselves. And to do this, we can do a lot more to better engage with and support civil society and community groups that are already working in these spaces. So that's all for me, and I look forward to working with all of you to continue to fight and advocate for respectful care for all people giving birth.
Thank you very much, Megan. And on behalf of patients and myself, As the lucky moderators of this session, we would like to thank all of you, the panelists, for sharing your work and wisdom, and of course, all the participants around the world who joined this session with us. I think there's a lot of work to be done, but we have also come a long way, like you mentioned and you talked about, and with so many partners and communities thinking and working on this issue together, the moment to align, amplify, and act is now. Thank you very much.